State your network, the Wi-Fi bandwidth.
Get any questions during your talk, then I will make a PPT of them. At the end, we will have the Q&A round. Okay.
Sure, sure.
Yeah. So with all your permission, I'm starting with the introduction. So, greetings and a warm welcome to everyone. I'm Sreyoshi, the assigned moderator from clirnet. It is my proud privilege to extend a heartfelt welcome to all the delegates joining us from across the country. We are indeed fortunate to have the valuable support of esteemed doctors and express my gratitude to each one of you for dedicating your time to be with us today. Allow me a moment to introduce our platform, clirnet. It stands as one of the largest live digital CME platforms in India, providing a space for doctors to create and share medical content. Now, I would like to extend a special welcome to today's distinguished speaker, Dr. Shilpa Sharuthi ma'am. Ma'am holds degrees in MBBS, DRNB. She's consultant intensivist in Hyderabad. And today, ma'am will be talking on the topic case-based discussion on prognostication in post-cardiac arrest. So, without any much delay, ma'am, now I would like to hand over this session to you. You can proceed with the talk. Over to you, ma'am.
Thank you so much. I would like to thank clirnet for giving me an opportunity to speak on this platform today. So,
You can share your screen now, ma'am.
is my screen visible?
Okay, it's perfectly visible. Please carry on.
So, good evening, everybody. Today's session is a case-based discussion on neuroprognostication in post-cardiac arrest patients. So, this is about a case that we had received at the hospital. So, this was a 67-year-old male. It was a known case of hypertension and CKD due to polycystic kidney disease on dialysis. He presented to an outside hospital in gasping state and had received CPR with attainment of ROSC within 15 minutes. Blood investigation suggested hyperkalemia. His serum potassium levels were 7.5, that being the cause of the cardiac arrest. Day 2 post cardiac arrest, he had a seizure with EEG showing epileptiform activity. Patient was then transferred to another hospital wherein he sustained two more episodes of hyperkalemic cardiac arrest requiring CPR with the attainment of ROSA. He was dialyzed thrice in that same hospital and thereafter he was shifted to a hospital for further management. So in the ER, he was sedated and ventilated. His saturation was 80%. His ABG was suggestive of severe respiratory and metabolic acidosis. But the important point to note here is that his pupils were bilaterally equal and reacting to light. Further, he was transferred to the ICU wherein we continued the sedation and ventilation, and he also was requiring inotropes, which was later tapered and stopped. And for the first 72 hours in the ICU, the patient had a GCS of E1, BT, M1 with bilaterally equal and reacting pupils. MRI brain was done, which was not suggestive of anoxic brain damage. Thereafter, he slowly regained consciousness gradually and but also developed myoclonic jerks. These myoclonic jerks were stimulus sensitive and they were persistent with intact consciousness. EEG, which was done, was suggestive of spikes with continuous background. So during his further stay in the ICU, he developed a ventilator-associated pneumonia, which was treated with appropriate antibiotics. He also developed a UGI bleed, for which he underwent an upper GI scopy and clipping. So he was tracheostomized and weaned off from the ventilator. And but his myoclonic jerks persisted. They were managed with levetiracetam and clonazepam. At the time of discharge, the patient was conscious, obeying commands, but had persistent myoclonic jerks. So our patient was one of the rare cases of Lanz-Adams syndrome, which is developed post cardiopulmonary resuscitation. It is relatively uncommon uh, finding in post cardiac arrest patients, which can be frequently confused with status myoclonus. But it is differentiated from the latter by the presence of an intact consciousness. And this entity is associated with a good neuroprognosis. So our patient had an in-hospital cardiac arrest and he was received by us on day 7 post-cardiac arrest with an unclear details of whether or not hypothermia was given at the outside hospital. So the factors which predicted good neuro outcome in our patient were bilaterally reactive pupils, MRI not suggestive of anoxic brain damage, and the presence of myoclonic jerks. We'll come back to this slide after discussing the various neuroprognosticating parameters. So the factors which caused delay in neuroprognostication in our patients were the prolonged sedation with midazolam and fentanyl, and also the development of confounding factors like sepsis. So neuroprognostication in post-cardiac arrest patients is extremely important as there is severe neuronal damage during the cardiac arrest, and only 30% of these patients have a favorable outcome. So once we are able to neuroprognosticate, it is useful because we are able to even give the family a consideration for withdrawal of life support in such patients when we know that the outcome is going to be futile. And also, but the prognostication sometimes can be challenging because the methods that we use can have confounding factors, such as the presence of sepsis, which was there in our patient, and also therapeutic interventions like hypothermia. So some of the confounding factors that we commonly encounter are the use of sedation. So midazolam and fentanyl, which we commonly use in the ICU, they accumulate and they delay awakening in patients with neuronal injury. So propofol can be used as an alternative, and but we have to because it is a shorter acting agent, but it still has to be stopped for a considerable duration before we proceed with the neuronal evaluation. Other factors such as electrolyte abnormalities like hypernatremia, hypoglycemia, encephalopathy, which can be uremic, hepatic, or due to septic multi-organ failure, and unrecognized seizures leading to post-ictal state and inability to wake up, and also a coexisting traumatic brain injury. All these factors can also cause a depressed sensorium, and it can act as a confounder when we want to assess the neuronal status of these patients. Along with this, hypothermia is also an important confounder. So this slide basically summarizes the landmark trials that we have in terms of hypothermia in post-cardiac arrest patients. So the HACA trial, which came out in 2002, emphasized the role of hypothermia to 32 degrees in out-of-hospital cardiac arrest patients with a shockable rhythm, that is a witnessed VFVT rhythm. And hyperion trial subsequently, which came up, showed that there was a role of hypothermia in out-of-hospital cardiac arrest patients, even with non-shockable rhythm. But the game changer was the TTM trial, which was out in 2013, wherein they did a study of comparison between 33 and 36 degrees Celsius. And they found out that it did not differ the outcome. What actually changed the outcome was if we control fevers, that is, if hypothermia overshoot was managed. So the AHA and ERC guidelines in 2015 said that 32 to 36 degrees Celsius for 24-hour duration can be maintained, followed by rewarming. TTM2 trial, which came up in 2021, again suggested that 33 versus targeted normothermia in out-of-hospital VFVT cardiac arrest. The value of hypothermia cannot be concluded. So therefore, there is a questionable role of hypothermia as of now, in terms of out-of-hospital cardiac arrest. In hospital cardiac arrest, again, we do not have enough studies to establish the role. So hypothermia, whether it is given or not, is going to be a confounder for our neuroprognostication. So therefore, we need to make sure that if hypothermia was instituted, we wait for a duration until we do the rewarming, and preferably at 72 hours, we need to start evaluating the neuron status. So the tests that we use to assess the prognosis are the clinical tests and the ancillary tests, such as the EEG, SSEP, that is somatosensory evoked potentials, biochemical tests, and imaging, such as CT and MRI. So we need to understand that before we use any test, we have to understand what is an ideal test and what is the false positivity rate of the test. So an ideal test is one which has a zero false positivity. So therefore, a highly specific test will have a zero false positivity rate. And that is what we need to make precise decisions. So a test that we we are going to use should preferably be something which has a lower false positivity rate. And the confounding factors that we talked about, along with hypothermia, all of these will increase the false positivity rate, and therefore they will decrease the specificity rate of the test. And it will therefore change the prognostic value of the tests. So if hypothermia is given, a delayed testing after V-warming, and particularly post-movement of the test to 72 hours and after is preferred. So this is a rough sequence of neuroprognosticative tests as the time windows from starting 24 hours until 96 hours. So it starts with a clinical neurological examination, which needs to be performed serially. And as discussed, it needs to be started after 72 hours if hypothermia was instituted. EEG again after 24 hours is going to be the most helpful, and the evolution over time is going to add a lot of information. CT can be also done after 24 hours, wherein the sensitivity for edema, the cytotoxic edema is what we're going to see on CT, and sensitivity for that will improve over a few days. SSCP again is performed after 24 hours, but it is unlikely to add any additional information if we already have an EEG pattern, which is a benign one. MRI should preferably be done after 48 hours. That is, the time frame is between 2 to 7 days. Now, this should be considered if the EEG clinical findings and the CT data appear contradictory. Otherwise, it is unlikely to provide any additional information if we already have a CT which shows an equivocal edema. So this is basically a very simple algorithm that can be used to for the outcome prediction in survivors of cardiac arrest. So when we have a patient in coma, we need to first exclude the major confounders that we have already discussed. And then if we go on to see for the brainstem reflexes, the pupillary, corneal reflex, oculocephalic, and the cough reflexes. If one or more of these brainstem reflexes are intact, then we need to go ahead and if one or more, if one or more of these tests are absent, then we need to go ahead and do the brainstem testing. Otherwise, on day one, if the patient has a myoclonic status epilepticus, that would suggest a poor outcome. And from day 1 to day 3, if there is absence of N20 responses on SSCP testing, that again would suggest a poor outcome. Between day 1 to day 3, serum neuron-specific enolase, the serum NSE levels more than 33 microgram per liter will again suggest a poor outcome. And after day 3, if there is absence of pupillary or corneal reflexes and absence of motor responses other than extensor, all of these will also point towards a poor outcome. So we will talk about each of these clinical tests in the coming slides, but what we need to remember is the timeline of events. So status myoclonic jerks on day 1 and absence of pupillary and corneal reflexes on day 3 are going to be one of the very important clinical signs that we would be coming across. Neuron-specific enolase is again, some of the labs we don't have it, and also the turnover time could be prolonged. So that again could be a problem. But what we can clinically see is the events at day 1 and day 3. So the clinical tests include the motor response to pain. Now again, this has to be assessed at 72 hours. Patients who obey command, that is going to be an excellent indicator of an excellent outcome. Localization to pain suggests good outcome, whereas withdrawal to pain could also be taken as a mildly optimistic sign. Other responses like flexor posturing, extensor posturing, or no response, all of these are going to suggest a poor outcome. And this test again has a false positivity rate of 27%, irrespective of TTM or no TTM. That is, whether we give hypothermia or not, this is still going to have a high false positivity rate. Pupillary reflexes, again, are fairly resistant to the effects of sedatives and paralytics since they have the smooth muscles which are not affected by the paralytics. So pupillary responses within first 24 hours is non-specific. So after 24 hours, if there is emergence of pupillary responses, that again could be taken as an optimistic sign. But more importantly, at 72 hours, absence of pupillary response has a 99% specificity for a poor neurological outcome. And after 96 hours, again, the lack of pupillary responses bilaterally would have a 100% specificity. So this is important for us to remember. Also, corneal reflexes after 72 hours has a 95% specificity for a poor neurological outcome. After 96 hours, absence of corneal reflexes again has 100% specificity. So both corneal and pupillary reflexes, if they are absent at 72 hours or even at 96 hours, that is going to be one of the important findings. But we need to remember that none of these tests are to be interpreted alone. It has to be a multimodal approach. We'll be talking about it in the later slides. We have to consider uh, a spectrum of tests and both the biochemical, clinical, and imaging, and then put it together to neuroprognosticate. Any particular sign taken alone could be misleading. So EEG again, that is usually understood as a combination of a background pattern plus a superimposed activity. So there are two types of background activity, a continuous and a discontinuous pattern. So continuous pattern is again a favorable out. It indicates a favorable outcome. And if a continuous background can be achieved within 12 hours, that will be an optimistic sign. And nearly all patients with favorable outcome will achieve continuous baseline within 60 hours. Whereas discontinuous pattern, wherein there are periods of separation, that is flat EEG, that occur between 10 to 40% of the time. That is not a good sign. And specifically, discontinuous pattern, which occurs very late, that is after 120 hours, is associated with a poor prognosis. Burst suppression is bursts of EEG activity which is present on a flat background with no EEG activity for majority of the tracing. This also has a false positivity of 20%. But burst suppression with identical bursts is also consistent with the malignant pattern. So burst suppression and discontinuous pattern along with suppression. Suppression that is defined as an EEG where more than 99% of the activity has a less than 10 microvolt amplitude. That is very flat EEG. So flat suppressed EEG occurring more than 24 hours after the ROSC has a 100% specificity for a poor outcome. So all these are going to be indicators of poor outcome with suppression being a 100% specific parameter. Superimposed activity can be seen in status epilepticus. It has a false positivity of only 7%. So usually, like we discussed, status myoclonus, status epilepticus will have a poor outcome. But patients sometimes who have had a continuous background prior to the development of status epilepticus or status epilepticus which occurs later in the course, sometimes they do well. The next entity is a reactive EEG. So EEG reactivity is referred to a change in the EEG background activity in response to external stimulation, which can be observed despite the use of therapeutic hypothermia and sedative medications. This again, when used as part of the multimodality approach, will have a good specificity of 99%. Then comes myoclonus. Myoclonus are of two types, the generalized status myoclonus and Lance-Adams syndrome, which we saw in our patient. So generalized status myoclonus is when there is an onset within 48 hours of arrest involving all the four limbs and the face. These should be synchronized, they should be repetitive, symmetrical, and persisting for more than 30 minutes. This again has a 100% specificity for a bad outcome, especially on day one, as you've already discussed, will be a very important prognostic sign. Lance-Adams is the other type of myoclonus. So basically hypoxic myoclonus, this was first reported by Lance and Adams in 1963. So this is a syndrome which is common in patients undergoing CPR. So the identifying features would be that Myoclonus in this particular entity will emerge later. That is, after the occurrence of cardiac arrest, this emerges after several days. And the patients may not be comatose in this. Like in our case also, the patient was conscious. Like he had gained the consciousness when he continued to have myoclonic jerks. So myoclonus, which occurs while the patient is attempting to move, that is intentional myoclonus, and it is also triggered by stimulation. EEG will show a continuous or a reactive background and the presence of spike wave discharges which are synchronized with myoclonic jerks. So this basically carries a good prognosis. That is what we have to remember. It's a rare condition which is seen in less than 200 cases reported so far, and this was seen in our patient. So it was very important to distinguish Lance Adams, that is myoclonus, which occurs along with intact consciousness during the later course of the cardiac arrest, from status myoclonus. So SSAP again is one of the very important tools. It involves stimulating the hand with electricity and tracing the nerve impulse from the periphery to the sensory cortex of the brain. So failure of the nerve impulse to reach the cortex indicates that there is a cortical damage. That is what we see as an absent N20 wave. So bilateral absence of a cortical signal for more than 24 hours has a specificity of 100%. So intact SSEP with amplitude of N20 more than 4 microvolts indicates a favorable outcome. But if the amplitude is less than 0.62 microvolts, that would also again suggest an unfavorable outcome despite the presence. So just the presence or absence of N20 is not important. We have to make sure that the amplitude is more than 4 when we can say that the patient will have a favorable outcome. This again can be depressed by barbiturate coma or but then it is preserved with other sedatives and also hypothermia. So that is an important point to note. So the technical competence that is involved is what is sometimes important, which can reduce the false positivity rate due to artifacts. Then comes the imaging, the CT scan, where we look at what is called as the gray-white matter ratio. So gray-white matter differentiation is reduced because of the presence of cytotoxic edema. So we look at 4 different specific points: the caudate nucleus, putamen, corpus callosum, and the posterior limb of the internal capsule. So the gray-white ratio is calculated, and if a ratio comes to be less than 1.21 after 24 hours, it is fairly specific for a poor outcome. Another important sign is what we call as a pseudo subarachnoid pattern, because it resembles the subarachnoid hemorrhage, wherein we see a symmetrical hyperintensity around the basal ganglia. But then this doesn't extend up to the cerebral sulci. That would be the differentiating point to note. The reason that this happens is because of the superficial venous structures which get dilated as a result of increased intracranial pressure. So presence of these signs would again indicate that the patient has had a hypoxic cytotoxic brain injury. MRI is useful, as we mentioned, when the CT doesn't show any anoxic injury. So the optimal timing to do MRI is between 2 to 7 days. So first 48 hours, there wouldn't be any specific findings. We need to ideally wait for 48 hours before we go ahead with MRI. And if the CT has already suggested features of edema, then it is not going to add anything more. So the absence of diffusion restriction in the cortex or the deep gray matter on MRI is going to have a 80% specificity for a good neurological outcome. Biochemical tests, like we discussed, the neuron-specific enolase is an enzyme which is released due to brain injury or hemolysis. So the cutoff value for this particular test will be 0.33 nanogram per deciliter. It has a 0 false positivity rate. That is why it is a very important test. But the test is unavailable at many centers, like I mentioned, and the cutoffs are still not standardized. And also the turnaround time could be quite high. So rising values of this enzyme is again going to predict a poor outcome. So therefore, we need to understand after discussing all these tests, that our approach to a patient with post-cardiac arrest, post-cardiac arrest comatose patient has to be a multimodal approach. So at 0 to 72 hours, supportive care and serial neurological evaluation needs to be continued. We have to first and foremost avoid all the confounders and then obtain a prognostic information if they're not withdrawing to pain with a video EEG, CT scan, serial neurological examinations or MRI between 48 to 72 hours. If the patient meets the criteria for brain death, then we go ahead and declare brain death. If not, and if at 72 hours, the patient has a withdrawal response, that is either a localization or a withdrawal to pain, that, as we discussed, would be a favorable prognosis. If not, then we are going to go and do the other tests and the presence of two or more of the following, that is, no pupillary and corneal reflexes at more than 72 hours, bilaterally absent N20 SSEP wave at more than 24 hours, or the presence of highly malignant EEG pattern, that is the suppressed background or a burst suppression at more than 24 hours. Early status myoclonus within 72 hours, diffuse anoxic injury on brain, CT or MRI, and the presence of an NSE, which is more than 60 microgram per deciliter at 48 to 72 hours. Presence of any two or more of the following could again suggest that the patient is definitely going to have a poor prognosis. If none of these are present, then again, the prognosis is unclear at that point in time. We need to continue the support with serial examinations and evaluate and see for any confounding factors that we discussed. We need to rule out the causes of delirium and then add tests which have not been already obtained, like SSEP or MRI. So the key to neuroprognostication is serial examinations, multimodal approach, and to stick to specific tests which are having good specificity. Absent pupillary reflexes at 72 hours, status myoclonus more than 24 hours, and bilateral absent N20 responses. These are some of the tests that we discussed, which are having 100% specific specificity towards a poor outcome. Thank you.
So thank you, ma'am. Thank you so much for the comprehensive talk, ma'am. It was really very informative. And so we have received few questions from the participating doctors. So if you allow me, I can share my screen, ma'am, and show you the questions.
Yeah.
Thank you. So I hope my screen is visible to you.
Yes.
Yeah, here is the first question.
So how should the healthcare team address situations where there is disagreement about prognosis or care plan? So this is one of the very commonly encountered situations in our practice. There can be situations where there is disagreement even between different specialities, the primary team, the treating consultants, or even the critical care team. So the key towards approaching such situations is always a multidisciplinary meeting. When we know that there is a patient who's uh, going to have a stormy course in the ICU, is going to have bad prognosis, we need to sit up, we need to like have a multidisciplinary meet and discuss about the prognosis, discuss about how time frame is important, how repeated examinations could be important. We need to continuously update the family and the relatives about the condition, and once we are relatively sure after putting all the tests that we've discussed that the patient is going to trend towards a bad prognosis, we have to explain to them about end of life care and withdrawal of life support. So it can be a difficult task to deal with. So therefore, it has to be done in multiple sittings. It has to be dealt with a lot of sensitivity. And we need to have a consensus. We need to approach it as a multidisciplinary approach, like involving all the treating teams along with the intensive care team. How can prognostic uncertainty be communicated effectively to the healthcare team and family members? I think I've just answered that question already. It has to be done not right away. It has to be done in multiple sessions. We have to keep discussing, we have to keep talking to the relatives, tell them the situation of the patient and how certain tests are important. And over a period of time, we have to slowly sensitize the family and help them make a appropriate decision. How can neuroimaging modalities like CT and MRI aid in assessing hypoxic brain injury? So, like we discussed, CT is going to be the first thing that usually will be considered. And if the CT is done, again, signs of cytotoxic edema could suggest that there has been a hypoxic injury to the patient. So, again, CT or MRI alone should not be used. It should be used along with the various clinical parameters, the biochemical parameters if it is available, and along with SSCP, EEG, and other tests that we mentioned. So it has to be, all has to be put together to come to a diagnosis. And MRI also, we need to wait for 48 hours before we go ahead with the MRI. What is the utility of EEG in predicting neurological outcomes? So EEG is very important. Firstly, like I said, to differentiate between status myoclonus and a Lance-Adams syndrome. Of course, apart from clinically differentiating features, EEG will also add to it. Presence of continuous background pattern, as we discussed, within 12 hours. Those are going to be indicators of good prognosis. Presence of burst suppression or a suppressed EEG would also indicate that the patient is going to go for towards a bad prognostic segment. So EEG is important, but after 24 hours and serially doing continuous EEG was what is preferred.
So, ma'am, these are the all questions which we have received from the participating doctors. Thank you so much, ma'am, for answering all the queries. And I would also like to thank all the participating doctors also. And I would like to request you all to follow us on our Facebook, Twitter, LinkedIn, and Instagram pages for more medical updates. Thank you so much, ma'am, once again for your valuable time and for being with us. So, with this, can we conclude the session over here for today?
Yeah, thank you so much.
Thank you, ma'am. Thank you so much. Have a good night. Thank you. And we hope to have you again. Thank you so much, ma'am.